A very warm welcome to the Kiel Imaging Seminar. We are very grateful to have you here tonight, Christoffer Laustsen from Aarhus University. So Chris, to those of you who may not know him, is a professor for translational MRI and the head of the MR research department at Aarhus University of Denmark. He has over a decade of experience in ex-nuclear NMR and MRI, in particular in the field of hyperpolarized carbon-13 MRI and metabolic research. He has authored more than 160 peer-reviewed publications and received notable prizes such as the Lundbeck Young Investigator Award. Before we start, to the audience, please wait for your questions until the discussions. There we can have a lively round and chat. With this, without further ado, please, Chris, the stage is yours.
Well, thank you, Jan Bernd. Thank you so much. I hope I can shed some light on some of the work that we're doing and some of the work that other people are doing in relation to the use of hyperpolarized carbon-13 for cardiac applications. So here's a short outline of the talk. So for those, I noticed a few familiar names, so I hope I won't disappoint, but I'll go through sort of the basic understanding of what is hyperpolarization and how does that work, and what is it good for, and then I'll talk a little bit about if there is a place for hyperpolarized carbon-13 in the clinical toolbox, at least, but that's more an opinion piece from my side. So what is hyperpolarization? Well, it's something to do with magnets. You're currently sitting in a very small magnetic field, but a magnetic field at least. A Frick magnet is quite a bit larger than the Earth's magnetic field. A clinical scanner is typically around these 60,000 times higher than the Earth magnetic field. And so if we then talk about hyperpolarization, then we add on top these 10 to 60,000 times, that's roughly where we are at the minute, on top of this clinical scanner field. So it's quite a dramatic increase in signal gain. I'll be talking about DNP or dissolution DNP hyperpolarization, so I won't touch on the other technologies that exist. But common for them all is that they enhance signal by more than 10,000 fold. They do not rely on ionizing radiation. The cool thing about MR or hyperpolarization with MR is that we can distinguish between different chemical structures, so we can actually see more than one thing at a time. That means that we can actually acquire more than one biomarker at a time, and this is something that is currently also being investigated at UCSF, where they're injecting both copolarization of urea and pyruvate. So a lot of opportunities to combine and make even more advanced sort of biomarkers. And several groups are doing human studies. And this was sort of the pioneering work by Sarah Nelson et al. From the UCSF group in 2013, showing a prostate cancer patient here. So how do we go about doing it? Well, as I said before, we start with a magnet, a pretty large one, larger than 3 Tesla typically. So that's sort of the current state-of-the-art field that we use for clinical MRI. We need a large freezer. So a large freezer in the understanding that it's very low in temperature. So that's typically less than 1.4 Kelvin. Then we need a microwave oven that operates at a very specific frequency related to the magnetic field and also the electron paramagnetic agent and the carbon-13 of interest that we're looking at. And that's the radical and pyruvate that we have up here. And then we also need a water cooker so we can heat up some water. We place this mixture of the pyruvate or the sugar and the radical, the electron donor, in this freezer, the microwaves are turned on, the specific frequencies, and then we let it sit there for a couple of hours, and then we place water in the electric cooker, and we heat this stuff up to 120 degrees under pressure. And then we very rapidly, when we're ready to do the experiment, we force this hot water down on this ice cube, and we dissolve the ice cube with this very hot water. And out we'll get this green monster of a signal that is, at least for now, more than 20,000-fold enhanced in signal. So this is really the essence of the experiment. And this is a slide, one of my favorite slides that I've completely stolen from Damien Tyler's group at Oxford. And you can see here the original polarizer. So that's an NMR magnet. You have your freezer down here. You have your liquid helium. Up here you have the on top. I don't actually know if you can see my cursor. I hope you can, but I hope you can. So if you
we see it well.
Good. So up here you have the water, the heater, and water in it. And so you've had your microwave guide going in here and irradiating the sample in the freezer. And so now you're ready to do your experiment. So you heat up the solvent. You pressurize because this is under a vacuum. You take out the sample out of to avoid putting too much heat into the freezer here. And then you very rapidly, because we're opening up so that we'll suck in there. So we hope to avoid that. And then we place the stick on top of the sample here. And then we force this hot water down, and we get this wonderful green liquid out that preserves the hyperpolarization. And this is how it looked with the alpha polarizer in Oxford. So this is the electric heater. He's pressurizing. Moving the sample out, completely automatic here. And then you see the green liquid coming out, and then she runs. And there's a rat or a mouse in the scanner here. And then you see an injection of this green liquid that goes into the animal here. And what you're seeing here is a demonstration of real-time metabolism as it occurs. And this is really the only technology that can do this in this time span. This is the first pass metabolism as it unfolds. Now, this has evolved into a clinical product, and this is the GE Spin Lab. So this is in our lab. So this is Dewey and Mette, who's operating the clinical polarizer here. And so this is exactly the same procedure, and you see signal is the dissolution has just happened, so it moves into the quality control unit here, and there's being some tests are being done here, and you can get some readings out here to confirm that this is a safe to inject solution. And you have Lotte in here placing the syringe, giving the OK, preparing the MedRat power injector, and Nikolai is running the scanner and giving the injection here. And now you see the experiment. So he's looking at it strangely, but nevertheless, this is how the experiment works. So a relatively easy push button setup. Now there is more than 24 of these around the world, these spin labs that are doing, and most of them are now doing clinical trials. There's been published more than 80 publications with human data, and then there's been done more than 1,000 exams. I can't remember exactly the numbers. And what's really important to mention here is that no serious adverse events has been reported relating to pyruvate or the injection of the contrast. So it's a very safe contrast agent, and it's a very safe procedure. So that's just very important to mention. And again, it's important to mention that hyperpolarizations signals or contrasts are very different from the conventional way of creating contrast in an MRI machine, where we rely on the water signals and how they are making contrast by changing the surrounding tissues or relaxation properties. We are actually getting the signals directly from, or the contrast directly from, the molecules that we've injected. We're limited, and this is probably one of the greatest strengths of hyperpolarization, is that we only have a very limited time span. And of course, with any technique, there is something that it's good at, and this is only technology that only works for fast metabolic and functional processes. So this is first pass metabolism and hemodynamics. So we can image with this technology. This is very similar to what you get with F15 water PET. So it's very analogous to that technology. We are inherently spanning 5 dimensions. So that means that we have the 3 sort of conventional spatial dimensions, but we also have the temporal dimension. So where does thing go over time? And then we have the spectral dimension. So what does thing become? And I'll get a little bit into that in a minute. Because we're looking at carbon 13, there is no background. So it's very similar to what we just discussed with PET. So it's a very similar technology to PET, just that it doesn't rely on ionizing radiation. So it is very it mirrors very closely what you would get with a PET MR with F15 water PET or oxygen 15 PET. So it has this same short life or half-life, and then you have to have sort of the anatomical details from the proton scans. And then it allows us to, in contrast to PETs, to see the downstream metabolites that comes out of a tracer like pyruvate. We can see what they become within seconds. So this is our FDG, if you will. So we have a carbon 13 label on the first position here of pyruvate over here, and then when we inject this carbon 13 labeled pyruvate, it goes into the cells. And in the cell, it can be converted into lactate, alanine, or go into the mitochondria, where it can be cleaved off by PDH, and then in this pH-dependent by carbonic anhydrase, you can see CO2 or bicarbonate. So we actually get a signal like this, and even further out there is CO2, so you can even measure pH directly in some instances. But in reality, what we're seeing is these 4 to 5 peaks that gives a lot of information about the balance between the anaerobic and the aerobic metabolism, and so hypoxia in many ways. So it gives us a really strong handle into sort of the basic mechanisms that is in play in almost any diseases. And so how would that work for cardiac applications? Well, that was very early on imagined that would be important. And you can see here a proton scan of heart, and you see a balloon in the coronary artery here. So you have a balloon in there to sort of create an animal model of an infarct. So if we look at the pre-occlusion data, so this is a healthy heart, you see a very nice signal of bicarbonate. So that's the PDH flux in the heart here. And then you see alanine transferase, and they show really nice images of the normal functioning heart. If you create a 15-minute occlusion, so that is subclinical. And with that, what do I mean with that? Well, I mean that with the conventional proton scans, the heart's integrity is maintained, so we don't actually see any macroscopic damage in the anatomy. But you can already here start to see the metabolism obviously changes before the macroscopic changes. So this really sort of highlighted the promise for cardiac applications, a viability assay of the failing heart here. And then this is the positive control. So if you go to a longer occlusion, then you can actually start seeing that proton MR, which is a state-of-the-art imaging technology for cardiac viability, you can actually start seeing that you have your perfusion defect here, and you have delayed enhancement in the infarcted region, and then of course the metabolism is also changed in that. So in all reality, this is a technology that has a great promise to look at things before they go really, really bad, because we actually have some really fantastic technologies already, but this is really opening up the possibility of getting a view into something that we couldn't see before. And so this was then translated, and this was translated by the Chuck Cunningham group in Toronto, showing these very nice images for the first time in healthy volunteers, showing that we could get these, and this was really, and this was in 2016 that we saw these beautiful images coming out of the Toronto group here. So that was really, really a pioneering piece of work, and took a lot to get that to translate. So now that we can do that in patients, so what is there anything we have to think about? And obviously we know from cardiac PETs that we often have to use sort of different conditioning, or as fasting or oral glucose, or even glucose insulin infusion and potassium infusions to standardize the metabolic imaging, and particularly for cardiac application, because the heart is a sort of an omnivore, so it eats anything that comes past it, and it changes, and under normal circumstances it actually relies quite a lot on fatty acids. So that was something that we and others have asked this question: should we do something, and in particularly should we do something to standardize the heart? So we decided to have a look at some pigs here, and as you can see, there's quite some difference between being a fasted pig and then a fed pig. And if we look at the data here from the hyperpolarized experiment, you can actually see that we get a significant difference in some of these parameters, that we seem to get a higher lactate to pyruvate ratio, so it seems to create more of the metabolites if you're in the fed state. So we seem to get at least higher signal, and then this is what you can see. So in the fasted situation, we actually have a low uptake, but in the fed state, we seem to get quite nice images. And so that was sort of an argument for moving to the fed state. For a lot of the PET applications, they actually go a bit further and use this GIC modulation, where they infuse and completely control the glucose and insulin and potassium levels in the body to make sure that you have a very good uptake of FDG in the heart. And so we did an experiment with this. This is obviously a very challenging thing to do, and you have to have people sitting there for hours before you actually start doing this, and then they have to sit very still while doing it. So it's something that would add to the complexity of the experiment. But if you look at the results here, you can see that indeed we see sort of a similar trend, that it goes up, but the variability isn't much different from a pig that has been scanned over similarly many hours, but there are an increase after 2 hours. You can start to get this higher ratio. This was also done by the Oxford group, and they sort of pushed this even further into patients. And then here you're seeing some of the first. This is the first patients, actually, diabetic patients, and then you have volunteers up here, and they also investigated this phenomenon of which sort of area you should scan these patients in, and again they find a similar tendency that you in general you get higher signals if you're in the fed state, and then they also find that diabetics have a completely different metabolic switch here. So already here in this pioneering work by the Oxford group, you're seeing quite dramatic changes to the metabolism as you would have expected, but it's nice to be able to actually extract that kind of information from the carbon data. So another way of sort of improving the cardiac exams in the metabolic imaging space is to use rest stress myocardial perfusion, and also for metabolic imaging, at least that would be for our case. But you can see that you have this viability PET where you use the FGG signal and you have your perfusion signal, and you can use that information to sort of say something about what tissue is viable and which tissues are not viable, and also to look at other indications for cardiac diseases. But this way of using that cardiac reserve as a challenge test to sort of extract even more information is something that we wanted to investigate whether or not we could do something similar. And so we set up a sort of a similar test using adenosine stress in some healthy volunteers. And then we wanted to see if it was safe to do that combination, because anytime you do these kind of things where you're mixing up stuff, you have to consider whether or not it is safe to do these kind of things. And so this is the actual sequence we have here. And so that sequence was sort of set up with the help of Rolf Schulte. And you can see here you have a single arm spiral on the metabolites, and we actually had a double arm on the pyruvate signal, because we have so much higher signal, and we also have a lower flip angle here on pyruvate, and then we scanned 3 times as often on the pyruvate to sort of get the hemodynamic information at a higher rate. But this is sort of the data, as you can see here, that comes out of the scanner, and you can see this the pyruvate up here and then the metabolites down here. So this is how it looked, and here we went with the oral glucose tolerance test as a normalizer. So you fasted for 8 hours, and you got the glucose, and you got your scan, and then we redid the exam on a different day with the adenosine. And this is how the data looks. And so the results from this is that, again, in the rest situation, we have okay signal, but when we start to go to the stress situation, you actually start to get quite a lot more signal. So it's sort of you're adding on top. You can see down here. Of signal, so you have higher delivery, and you therefore also get higher metabolism, because your heart needs more energy, and so you actually get nicer images in the stress situation than you have in the rest situation. So that's similar to fasted and fed. Now this is both fed in this case, but we are increasing the signal once more here. And again, you can see that the conversion from pyruvate into lactate, the conversion from pyruvate into bicarbonate, they all go up here, and alanine as well. So we have sort of a nice increase here, and what you would use this for is to sort of, if your heart is failing at a at the high stress, then we expect this sort of delta value to not respond. So you're basically creating a situation where you're pressing the heart so that you will be able to find or pick up minor things. And so we strongly believe that this is something that we can add to the cardiac workflow eventually and increase the sensitivity and specificity. And as you can see here, obviously the metabolism is closely correlated with how much the heart is doing. So that is sort of, it's a nice relationship to be able to find. So just in summary, we can do this. We can do the sort of conventional rest stress imaging situation, and it seems to be fine to do that. And we see an increased flux of pyruvate in these patients, or in healthy volunteers, sorry. And so that opens up for this possibility of increasing the sensitivity for diseases eventually. Now, sort of going into a little bit more of the sort of the diseases that we can do. This very famous paper, The Failing Heart, an Engine Out of Fuel, coming out of the Oxford group. And as you can see here, we and others have done this in the past to look at this infarcted. So that's basically the same model as I demonstrated to you earlier, and in a pig model. And you can see that we get these different, well, in the infarcted region, and this is the remote region, and you can see that there's quite a difference in these signals. Interestingly enough, this seems to sort of be the other way around in this case. And you can also see here where we used the fumarate that we see quite a lot of malate being produced. So this is a necrotic situation. I can't remember the time frames. This is some unpublished work, but you can see down here, again from the Oxford group, showing that in this situation you can use this other tracer, fumarate, to actually decipher where you have necrotic, acute necrotic tissue. And so this is something that could really help in the sort of deciphering treatment effects and how much damage you have in your infarcted region. And again, this has been pushed into patients, and this is again courtesy of the Oxford group here, that they've shown in patients here some pioneering work showing that the infarct here, and again some other images, and you can again see that there are differences across this heart, and this is the infarcted regions here. We've also looked into heart failure in Aarhus, and so this is our study that was just recently published in 2024. So we had 12 patients with chronic heart failure. 6 patients had ischemic heart failure, so that's the infarct. And then we had non-ischemic dilated cardiomyopathy as a sort of control group with a non-localized disease. And so how does it look? Well, you can start to get these bullseye maps, and then you can see that you have these defects where you have metabolism going down, maybe you have lactate going up, etc. And so you get this lactate or bicarbonate change that are quite dramatic, and you can see the strain is also changed in that area. So things sort of start to sort of align for these examples. And so what we wanted to do was to look at what happened to people. So we started scanning these patients, and then they go to whatever treatment they have. So they open up, they remove the blood clot, and then we see what happens to them after this, and then they start their treatment. So can we actually see a change in these patients after a year. And so if we look at the delta ejection fraction, ventricular ejection fraction here, from baseline, so that's when we scan them, till 1 year later, we can actually see a very dramatic relationship in the patients and their baseline lactate to bicarbonate ratio. So there is no other method that can predict this with this high certainty. And so this is something that we're looking into now, is to see if we can look at introducing a baseline scan to predict which patients that would have a worsening, which patients that would have the benefit effect of, and who does not have an effect of the treatments that we have planned for them. The unfortunate truth is that right now they're all getting the same type of treatment, so we actually don't know what to really do with this information at present. And so we're actually also moving a little bit away from doing FTG in Aarhus at least, and I don't know if that's the same in other places, but that's because water PET is so good at predicting these kind of things. But it's something where we don't really know until we have something that can change what we do. So it's a nice tool, and it looks like it's very promising, but right now we don't have a killer application to use it for, because we don't have another treatment in our arsenal at the moment. So in summary, we can actually detect these changes in pyruvate metabolism in the chronic heart failure patients, and the poor contractility is increased. I mean, is associated with an increased signal in the lactate pool and a reduction in the pyruvate oxidation. So we're seeing this shift in metabolism. So the outcome is totally related to what we would call Pasteur hypoxia. And so this correlation is something where we can use to predict the outcome of a patient a year in advance, and no other technology has that ability. So I think we have quite high hopes that this technology can be used for some good in this patient population. And so now that we can look at these effects and it looks like we can predict them, then another open question is, can we use it for something meaningful? In terms of, can we actually start treating them and seeing that metabolic change? And so this is a little bit old data now, but we had this right ventricular heart failure model where we banded the aorta of these animals, and then we let them grow. And so what you can see here is a pig that had the operation, and then 16 weeks after, you see a massive increase in the lactate to pyruvate ratio, and you see this change over time, and you see that it suddenly starts to go down at week 12 to 16, in between that area. And if you look at a control group here, you see that sort of follows that normal line here. And so how does that look? Well, it looks like this. So you have your baseline scan here. The bicarbonate is a lot of bicarbonate early on, and very little lactate, and then it's completely reversed at 16 weeks. And obviously, this is the reason why it goes up here is because it actually is growing quite dramatically, this pig, and if you correct for it, it sort of stabilizes, but the effect is still the same. So you have this situation where the heart failure it's actually seemingly all right for a long period of time, but then at some point, then you have this switch where it completely changes over to this situation. So it's sort of a gradual thing, so you don't get chronic heart failure immediately. It's something that evolves over time, and this technology can sort of be used to monitor it and also predict it, and that's sort of also what we showed in the patient data I showed you earlier. And now, what about if we want to treat them? Can we do that? And then this was something that DCA is something that boosts the carbon oxidation, so we put these pigs on DCA treatment for 7 weeks here, and the hope was to boost the PDH activity here and see if that had a beneficial effect. And other people had previously seen positive effects of this in similar situations. And so this is the ejection fraction change. And as you can see, the controls there, they have a good ejection fraction, and then the heart failure group with no treatment has very poor. But you can see that giving them DCA actually maintains the contractility quite a bit, and so it actually saves the heart quite a lot. And if we look at the metabolism, you can see that bicarbonate is actually increased quite a bit here, and lactate seems to maybe go down as well here. So it sort of changes metabolism, and it's really under stress situation. That was what I was talking about earlier. If we then stress the heart, what happens then? Well, this is exacerbated. You see this dramatic increase in the capacity to drive things into the PDH enzyme here, and then that is on the expense of the lactate signal, or the lactate pool. And if we then correlate this with the oxygen probe experiment here, or Robus, then you can see that we have a very nice correlation between the bicarbonate production and the oxygen usage. And this is some nice work that Jack has just completed here, and that is looking at ketones. And ketones has been sort of postulated to be a super fuel that could help remove some of the problems that we're seeing, and sort of a novel treatment for a lot of diseases, but in particularly for cardiac. And so producing or giving ketones is sort of a super fuel that goes directly into the heart and being used immediately. And so it has been shown that it can increase the performance of athletes, but also that it can actually improve these NT-proBNP and then other markers in heart failure patients. So Jack asked the simple question, why is this? And then so we put some pigs on this eucyclemic hyperinsulinic clamp and added ketones. And so this is a study design down here. And so this is how the experiment looked. And in this case, we're actually using C2 pyruvate. And as you can see, this is the baseline, and then you see this the clamp, and then the clamp with ketones. And so you can see we increase the lactate here, but then when you add this super fuel for the heart, you start to drive metabolism in another direction. So you have this ability to change the metabolic favored fuel by adding this in the bloodstream. So this is the results, and you can see here how dramatic changes that we're seeing. So baseline to HIC here, you see glutamate going up, and then it completely vanishes here when you add ketones, and you see these dramatic changes in the results here. it also changes the workload of the heart. So it basically changes not only the metabolism, but also how the heart actually functions. So this is really lovely stuff from Jack. And then as you can see here, it actually underscores how metabolically flexible the heart is. And so if we look at these, so sorry, I thought they were on a different slide, but they're here. And you can see these changes, although these are not significant, but you can see here the cardiac output changes dramatically, and the heart rate, of course, also changes quite dramatically for both situations here. But it does look like the ejection fraction, if we had more animals, that there might have been something there as well. Yeah. So sort of to sum up, I think we can identify different diseases associated with heart failure, and also the treatment effects. So I think there's quite a lot of opportunities for hyperpolarization to sort of come in and be a thing for a lot of patients out there. It's a fantastic research tool, and so for sure it has an opportunity to change how we treat patients by allowing us to do studies and understand metabolism that we've not been able to understand, such as this study by Jack and his colleagues that I just showed you. But then again, when should we use it clinically? Obviously, this is sort of a big question. I think if you think about it, this is an alternative to PET in many ways. And so if you don't have access to water PET, because that is slightly difficult to set up everywhere, this could be an alternative. So I see hyperpolarized MR as a PET MR light, or with the opportunity to then add this first pass metabolism on top of the hemodynamic information, and so that you enable us to get similar, if not more, information that you would be able to get with a PET MR system. And so it's an opportunity to democratize and make hyperpolarization broadly applicable to a lot of patients that would not necessarily get the best opportunity to see these tools. So that's where I see hyperpolarization helping these patients immediately or in the close future. But of course, we don't know exactly which diseases or which indications that this will eventually be used for mostly, but I believe that there's certainly already now sufficient evidence to support this in situations where you don't have access to all the fancy PET tracers, but you could easily install a hyperpolarizer in an MR suite somewhere. And with that, I'd like to thank all the people who actually do all of this work, and thank you for listening. I'm happy to take any questions.
All right, Chris, thank you so much in the name of all of our audience. Fantastic talk and very interesting results. So I'm very happy that you came back as well to therapy control, because and that we can chat about. I think that's maybe the key thing where hyper may be applied clinically, right? I mean, not sure if there will ever be a screening tool like for everything, but if you have a dedicated therapy that you want to see whether it works or not, that could really make a difference.
Yeah, I think, I mean, we are moving into this personal treat. I mean, we've been talking about personalized treatment for so many years now. And of course, that is all lovely, but in order for that to actually work, we need to have tools such as this that can verify if the treatment that you're starting up on is actually working. And so this tool is the perfect companion for that, but that then requires us to actually have more than one solution. and right now, it's more the general thing is that we only have one solution and that fits all. And so we need to start thinking about having more treatments possibilities and actually utilizing the fact that we have a diversity in the patients. And so
Yeah, sure. Yeah.
right now it's I mean, so right now it sits as a perfect candidate for drug trials. I think it will have a huge impact there, but for the daily clinic where it could be used, you have to have alternative technology or treatments at your disposal, because otherwise you knowing, and this is the case that I was mentioning earlier, we're giving the same treatment to everyone.
Yeah.
So you will know, and that I mean, I'm not saying that is not nice, and I'm not saying that couldn't be relevant to if that is important to know for a given situation, then of course you can give the information to the patient and say, you're going to be all right, and you can just go home and you're going to be fine if you follow this regime. And then we can monitor the patients that are in the other end of that scale and say, oh, we would need to follow you more closely. But then following them more closely would then immediately get the questions asked, what are you going to do differently then? And that is where we right now we don't have the answers to that. And I think this is the catch-22 with this kind of technology, is that now we have the technology, now we need more treatments available for the individual patients.
I mean, I agree on the broad picture. You're absolutely right, but still, I think it's very crucial to identify responders, right? And of course, we may have in some cases therapies available and others not. Yeah. It's like I just think of 30 years work on the triple negative breast cancer. There, you may have surgery as an option, right? You identify responders like 1 week after treatment and not half a year after treatment. At first, you can offer maybe surgery, and second, you may save as well a lot of treatment costs. And
that is certainly really important. And I think, we need to show more of these this kind of use case scenario where, we have some actionable changes that the clinicians can introduce, because then that's what will drive the adoption of these technologies. Because if it makes sense for them to change something, then they will do it and use it. And it was not to sort of say that it's not important to know in advance, and we're quite happy that we can predict a year out in the future with so high certainty what will happen to the patients. So it was not to downplay that. It's just that we at the minute, because we don't have an alternative, the clinicians in Aarhus did not see an immediate use case for it. It's not that they're not excited about it. It's not that they don't see that it could be valuable, but they need to have then something that they can change.
Yeah, sure. If it doesn't result in treatment change. Yeah. I could discuss on and on, but I would like as well to invite the audience to ask questions. So is there anyone? Either speak up, please, and or post your question in the chat. While people do that or consider asking you, I meant to ask you as well, but I think that got resolved a little bit later on. When you showed your heart data, I was expecting to see a lot of pyruvate in the blood pool, but on the first images, it didn't look like that. But on the later images, it did. Was just a misconception of mine?
So you're talking about the data from the Malmö group. I guess I don't think that they actually showed the pyruvate data. So that's data from pigs back then. I
thought more of Cunningham's group, where there was a lot of pyruvate in the blood, lactate as well in the blood pool. Pyruvate and lactate both.
Yes. So in pigs we don't see a lot of lactate in the blood, but in patients or in humans there is a lot of lactate in the heart coming from the signal in the blood. So we do see that in patients, but in the animal models, not so much. So the pigs are a little bit different in that way.
Okay.
It might be that it's because they're under anesthesia. We actually don't know why that is.
Yeah. Okay. So then I just saw the pig images likely, and there was not that much lactate in the blood pool. Okay.
Yeah.
Anyone else? Otherwise, I'll ask you about your setup. So what coils did you use?
Oh, we use a lot of different coils. So we've had quite a different set of coils over the years. So some of the early work we used a 16-channel heart array from Rapid together with
receive?
No, so that was receive only, and the transmitter was we even used the original clamshell coil that GE developed, Jim Trump, and then that was later changed to a clamshell coil from Rapid. Now we're using a 4-rung Rapid transmitter, larger, which we're quite excited about. And then we've changed to mostly using array coils from JD Coils, and that was simply, I mean, they're much more flexible than the coils we've used in the past. And then we also used a Helmholtz loop pair from PulseTech for many years, and that was sort of our go-to coil setup. So we've had many different setups for this over the years, and we've tested a lot of different combinations of things, but we're quite happy with this new setup because now we also have the air coils from GE, so that we can fit larger patients and in the scanner at the same time.
Yeah. So your conclusion from that much experience would be sort of the 4-rung transmitter plus what kind of receive coils?
We have, I think our current one is 16 channels, and I did the sort of the things that we've learned over the years is that we need them to be of a relatively large size, the elements. So basically we can have sufficient penetration depth, and then so it's a compromise you have to sort of deal with, and but yeah, it's 16, 32 channels.
Yeah, like on top and front, like on the chest, on the back, or just one-sided?
We've done both. The original one was 16 on top, 16 on bottom, and I think we're going back to something similar now. But we've had many different designs. Okay. I mean, you'd have to talk to Espen or lab manager to get the exact configuration. So we've done many different ones.
So last chance to the audience. So then maybe I have my last question, and this is just maybe a clarification question. When you showed the delta of the ejection fraction, I think you said it, but I think I missed it. That was like the delta in 1 year in the future after the medical event. Okay.
Yeah. So basically, it's when we titrate people up. So they've had you have the surgery or the revascularization, and then at that time we scan them, and then a year. I mean, and then at that time we also know what the ejection fraction is, and then that doesn't correlate with the outcome. But the bicarbonate to lactate, so this balance between the anaerobic and the aerobic metabolism, sort of in Pasteur sense, has a extremely strong correlation, stronger than anything we've ever seen, with the outcome. I mean, that delta from that time to 1 year later.
Yeah. Outcome in terms of reduced ejection fraction.
Yes.
Yeah, very nice. I mean, that could be just the information that we need, right? That could be those things that makes a difference.
Yes. So if you have, I mean, let's say you had an alternative. Let's say you could, if going in and doing the surgery again, or changing something, if you had something at your disposal that would change the outcome of those patients that. And I think it goes without saying that this is the hard situation, but let's say in other situations where we have something on the shelves that you can do, then this kind of setup is directly clinically applicable, because then they can test if the intervention that they've done was good enough, and then they can redo it.
Yeah.
And that would save patients potentially, quite dramatic decrease in life quality. And
I could as well see that once it's known that there's a defined cohort that doesn't respond, and you can identify them, maybe that even would stimulate further research or progress.
Yeah, and you can select those for. And then you can select them for drug trials, for instance. So that's the other thing, is that you say, okay, we have this population that will never improve. Can we start testing stuff in them? And so that would be a way to select them for that drug trial, is to use pyruvate for that. Is to sort of say, okay, this population will not improve. And then if you then come up with something that improves it, then then you have it. So it's we're halfway there, but we still need to introduce something that would change it for in this situation. But I'm sure that in other diseases, you could where there are alternatives.
And of course, for all of that to work, right, the technology has to work reliably, which brings me to my very last question. That is, you showed that you used some spiral sequences. How did you make them metabolite selective? I guess that was maybe spatial temporal excitation or something.
So that's spectrospatial excitations, and we've been lucky to work with G and Rolf Schulte. So basically, all of these sequences comes automatically for us because Rolf has set it up so nicely. So it runs on the G platform directly out of the box, nice. So it's something where the barrier to entry for that is very low, and then you can just start scanning immediately. So it's more for this. You can buy all of this stuff, right? So it's if you have if the clinical indication is there, I don't see any barrier to for anyone to enter.
I mean, of course, we're always at the fringe of SNR and resolution, right? You need to still draw the ROIs and evaluate your signal, and the better your voxels are, the more accurate you'll be able to quantify metabolites and stuff.
Yes, and that is absolutely correct. But in this case, it was actually the full heart. So this would even work with a spectrum. So this would even work with super low
I didn't get that.
signal. So this is as simple and stupid as it gets, and so that is actually something that maybe I didn't explain that, but we haven't actually looked into regional things yet, because this works so well with the overall.
You just took the entire volume of the heart, or the ROI of the entire heart. Yeah, nice.
The ROI of the. So and that essentially just means that your disease is as you would expect. It's not. What determines what the rest of the heart can do a year in the future is not determined by the size of the things that are not recovering, but actually of the rest of the heart, right? So it sort of it kind of makes sense, right? So it follows that of course the signal from the viable myocardium is what, or failing viable at that time myocardium is what determines the capacity.
Yeah, so possibly we can go back to a surface coil just lying on the head and acquiring a non-localized spectrum.
That is certainly not completely out of the realm.
Yeah. Of course, I love to see those images too. So thank you so much, Chris. That was very, very interesting. Thanks for sharing everything with us and spending the evening.
Thank you.
Hope to see you soon. Thanks to the audience. Thanks for being with us tonight, and check out the next KIS seminar.